What's up, everybody? Welcome to the Med Easy Show. I'm your host, Dr. Mo. Now, before I go into the video, please do like the video, subscribe, share this content. I know I said like, but this is what the video it is kind of beneficial. I think if you have a medical background, it will be very, very beneficial. But if you're also interested, there's something you could pick out. Anyways, let's go into the video. Hello, everybody. Welcome to the Med Easy Show once again. This week we'll be talking about secondary head injury. We did cover primary brain injury in the previous video, but the key difference between the two is just a matter of time. While primary brain injury is usually at the site of accident or fall, and it usually takes less than seconds for it to persist, and some of the conditions you see are those of neuronal damage, contusions, lacerations, and shearing lesions. While secondary head injury usually takes a bit more time, you have it developing over hours to days. Alright, now we'll first start talking about brain edema, though we did cover a bit of it in the previous video. Since it progressively again takes a little bit more time, it's necessary to look at it. What you also need to understand is that the edema sets in due to the release of those pro-inflammatory cytokines, which result in brain swelling, which result in reduced supply of blood to the areas, resulting in progressive hypoxia and even brain necrosis. So your plan of care is based on measures to reduce those ICPs. So you prop up the bed, give your oxygen by mask, you support your patient by giving hydration, by monitoring the hydration status. Bladder, bowel care, and nutritional support are essential. We move on to the acute epidural hematoma, and this is usually a neurosurgical emergency. Almost always occurs due to an arterial bleed that almost always again occurs due to the terion site injury. Now, what happens is this blood gushes from most commonly middle meningeal artery and gets in between the dura and the bone of the cranium, in between those areas. Progressively, the hematoma expands. The ICP compensation point is passed beyond. Now, progressively leads to a midline shift and hemiparesis, either ipsilateral or contralateral. Ipsilateral hemiparesis occurs in something known as the Kinohan's notch, and we'll see it in the next slide, if I'm to say so. What happens is, as progressive brain swelling occurs, midline shift occurs, the section of the brain that is the swelling presses against the opposite side, and it presses the area which is pressed is that of the corticospinal tract. So you end up having the same side weakness. You also watch out for other symptoms, those of lucidity, which means gaining and losing consciousness in less than a few minutes, and then those of increased intracranial pressures, vomiting, headaches, and all those. A CT scan is usually diagnostic, and an acute setting always shows as a hyperdense lesion. An epidural will almost always look like a glass eye or a biconvex lens. Now, which is CTs are really, really accurate when it comes to diagnosing them. So your plan of care is usually always emergency neurosurgery. Prepare your patient, get your consent. Blood sample is usually necessary. Take your patient for a craniotomy, an emergency craniotomy, usually 5 centimeters on the parietal area, just above the zygoma on the affected site. Do a bar hole, localize the clot, evacuate the clot, get the vessels, cauterize them, do a dural hitch to the gallia, and then postoperatively monitor your patient, BPs and analgesia, and antibiotics as well. We move on to acute. Subdural is usually more serious than epidurals because there is associated severe brain damage when you have an acute subdural. And the issue with acute subdurals is that you're bleeding from the cortical vessels, meaning the cortex of the brain is the one which is severely damaged, and the blood accumulates between the brain and the dura. The most common mechanism of injury here is that of a coup counter coup mechanism, which means that if you did physics, the action reaction kind of effect. The patient also presents with those histories of loss of consciousness, bradycardia, Cushing's triad, basically. Uh, CT imaging shows a crescentric hyperdense lesion. Usually looks a bit like a moon, and hyperdense meaning it's acute. If it was chronic, then which we'll see. Your plan of care is based on anticonvulsants, and you can schedule for a craniotomy, which is essential, similar to the previous slide of an acute epidural. Now, the chronic subdural is usually common among the elderly who have undergone brain atrophy, and the bridging vessels are the ones which rupture, so the blood keeps on slowly leaking. Usually takes time. Now, the my mode of management is just analgesia, antibiotics, and you can schedule for a craniotomy after adequate preparation of the patient, especially with the coagulation profiles of these patients, because you never know who has a blood or coagulation disorder. Now, the concept of anticonvulsants, I think it's, as per my research, they say usually give it for 3 years, but I think we need to delve more and look into more papers. I'll try and put the links in the description. Move on to subarachnoid hematomas, and you have two types. You have the traumatic subarachnoid hematomas, and it's usually a type of an intracranial hemorrhage into the subarachnoid spaces, usually along the basal cisterns. And you also have the aneurysmal type, usually follows due to a rupture of those aneurysms, the Berry's aneurysm specifically. The patient will almost always present with a thunderclap headache, hemiplegia, loss of consciousness, and sometimes focal neurological deficits. The causes of this aneurysmal or aneurysms can be due to infections. In the cases of microorganisms such as bacteria, especially patients who ended up or having a history of endocarditis. Other causes are those of surgical or traumatic kind of causes of this aneurysms to occur. An aneurysm is an abnormal dilatation. The plan of care is usually getting a CT scan, CSF, which is usually a bit risky because you have a risk of colonization. A CT angiography is very, very important because it does really point out to where you have the aneurysm. Nimodipine is a calcium channel blocker, and it really helps in reducing vasospasms. And again, vasospasms are more common in aneurysmal subarachnoid hemorrhage compared to traumatic subarachnoid hemorrhage. And then when it comes to management of this, you can do a craniotomy and clip, or you can do an endovascular embolization, also known as coiling. We move on to the last bit, which is the skull fractures, where you talk about the closed linea, where you usually manage conservatively unless there's a wound, you do some debridement or toileting, and you do a primary closure. And you just monitor the progression. Usually, linear fractures have a better healing capability. When it comes to fractures in the air sinuses, there are those which require exploration, those which don't. But the mode of management is almost always broad spectrum antibiotics because the risk of meningitis and brain abscesses are usually high. Depressed skull fractures usually happen when a small object hits it, and it's usually an indication for elevation is if it is more than 50% or depressed, and if it is depressed of an area where there's a sinus, it's usually never an indication because it's already offering the tamponade effect that we want. Gracias muchos. We have come to the end of the video. Anyways, this is the part where I always say, please like, subscribe, share, drop a comment down below. But I do mean it. I'm gonna look at them. I'm waiting for constructive criticism. I know there's a bit of a conflict between the audience and who is supposed to benefit more. But anyone who is interested, that's the whole point. If you really into medical stuff and you want to learn about something in medicine, I can be that guy for you. And if you're a med student, I'm definitely that guy for you. Subscribe.